Next speaker is Amy Pasternak from the University of Michigan, presenting on her experience implementing CYP3A5 and Tacrolimus.
All right. Good morning, everyone. I'm very excited to have the opportunity to be here to share with you the experience I've had over the last year, really focusing on a single drug gene pair. I am at an academic medical center, but we kind of have had a unique model where we've had more of a grassroots approach to implementing pharmacogenomics. University of Michigan Health, I am a faculty member at the College of Pharmacy at the University of Michigan, which is a separate entity, but I'm fortunate to have a dual appointment at the University of Michigan Health as a clinical pharmacy specialist in pharmacogenomics as part of my role. And our healthcare system has just over 1,100 beds in Ann Arbor, Michigan, and a part of our services include transplant populations. And so we have multiple different transplant services. Each has a unique team of both pre-transplant evaluation, surgeons, and post-transplant management clinics. And in our healthcare system overall, each year, in both the adult and pediatric patients, we perform just under probably about 500 solid organ transplants. And additionally, we have a bone marrow transplant program in our cancer center where we perform about 100 allogeneic bone marrow transplants each year. And so Tacrolimus is our preferred agent in all of these patients. And we really were interested in identifying, is there a way that we can find value in performing pharmacogenetic testing for these patients, given the complexities of managing tacrolimus in terms of all of the therapeutic drug monitoring and burden that places on our patients and providers. So for those who might not be familiar with this drug gene pair, I just wanted to quickly kind of summarize what our existing available evidence is for this drug gene pair. So tacrolimus has a very narrow therapeutic window. It requires extensive and lifelong therapeutic drug monitoring. We've learned that pharmacogenomics is a major player in the inter-individual variability we see in tacrolimus exposure with patients. And CPIC has a guideline for CYP3A5 and tacrolimus. And essentially, if you carry the normal function allele for CYP3A5, which is very rare in some ethnicities and very common in other ethnicities or cohorts, you require a higher dose of tacrolimus given the increased metabolism of that agent that you experience. And in most practices, this isn't known ahead of time. And so the FDA label for tacrolimus actually suggests using a higher dose of tacrolimus in patients who are African American receiving kidney transplant, because that happens to be the population where being an expressor happens to be more common. But it's still found in about 10 to 20% of European ancestry patients. And so it's not necessarily representative of the metabolism by just following sort of those ethnicity or race-based recommendations. So CPIC does recommend that if the CYP3A5 genotype is known and your patient is an expressor or has that active enzyme that contributes to increased metabolism, to increase the initial dose of tacrolimus to try to achieve therapeutic concentrations faster. And if the patient's a poor metabolizer, just to continue to use the standard of care dosing included on the package insert. Tacrolimus is also unique in that we do actually have randomized controlled trial data looking at genotype-guided dosing for this type of strategy. But one of the challenges when we think about going towards implementation is this data is kind of contradictory. So highlighted in this bottom table is a couple of studies that were performed in adult kidney transplant patients. The rows highlighted in red are those that found significant differences in terms of improving the proportion of patients who achieved therapeutic concentrations initially, reducing sort of the monitoring burden in terms of the dose adjustments of tacrolimus that were required. But another study that had a very, very similar design was negative and showed no value in sort of impacting these types of outcomes. One of the other challenges with implementation is oftentimes we use medication safety as the reason for pursuing this pharmacogenetic testing, as was really highlighted in the discussion this morning. But unfortunately, these studies and many others haven't shown consistent outcomes that using genotype-guided dosing actually changes the risk of rejection, which is our biggest concern when a patient has had a transplant. And so when we thought about implementing this drug gene pair, we really couldn't use that typical angle that we have for other pharmacogenetic implementation efforts. So I don't have time to walk through everything we kind of considered in our implementation, but I wanted to quickly highlight a little bit about our program and then some specific considerations that were kind of unique to working with transplant patients, but also working with this particular drug gene pair that I think might become more common as we see more drug gene relationships. So our pharmacogenetics program actually started in 2018. It's managed by myself and another pharmacist who are both part-time clinical, so we don't even have a full FTE of time, but we really focused our initial efforts understanding what was already happening in our healthcare system and trying to show the value of having a pharmacogenomics expert by improving the existing workflows. So improving the documentation processes, the ordering processes for our clinicians, and making sure that there was a consistent way to document that information in our medical record before trying to pursue new strategies for testing. And so this is one of sort of our first programs where we're really looking at adding new testing for our patients and having to justify sort of the value and clinical benefit of that. So I want to highlight a couple of things we considered, starting with our pre-implementation phase of looking at sort of our evidence. We were fortunate to have some internal data, and then really how did we engage our stakeholders in buying into this implementation, given the lack of impact the studies suggest on rejection. When we've approached other implementations, like I mentioned, we really had taken the medication safety approach in terms of when you're prescribing a new agent to a patient, regardless of what the indication or what the reason this patient's receiving this medication for, there's a safety concern. And so we want to modify therapy. And so with those implementations, we were able to sort of across the board in our institution apply a single strategy to make a recommendation at the point of prescribing. We knew going into these discussions with our transplant groups that although every single one of our transplant populations uses tacrolimus and uses it immediately post-transplant, they all have different protocols, they use different routes of administration, they may have different other factors to consider in terms of what your dose selection would be. And so we really felt like it was important to increase our feasibility and chances of success, that we look at these populations in detail before moving forward with any implementation specifically. And so, as I mentioned, we have 5 different transplant populations at our institution, but we've only implemented in one of them currently. And these are some of the specific reasons why that happened. In terms of tacrolimus formulation, our bone marrow transplant patients always receive intravenous administration of tacrolimus, and our lung transplant patients often receive sublingual administration while they're still intubated. And some of the emerging evidence that's available really suggests that when a non-oral route is prescribed, the impact of the genotype is not as significant as with the oral route. And so even though we have a CPIC guideline which recommends dosing, our concern was that if we applied that current dose recommendation, it actually would be too much for those patients and we'd increase the risk of experiencing toxicities. So we've opted to not pursue any implementation in those populations until those relationships can be better defined. Another really important consideration for our clinicians, because they wanted us to be able to provide a specific milligram per kilogram dose. They didn't want to have to think about, well, how do I double, do I do 1.5 times? And one of the things that we weren't able to answer was consideration for drug-drug interactions. So many of our patient populations start concomitant CYP3A inhibitors around the time of transplant, most commonly an azole antifungal, sometimes in our heart transplants, some other antiarrhythmics that cause those types of interactions. And we didn't feel the data was clear enough to say, how do we adjust for both genotype and a drug interaction at the same time? And we knew that if we implemented and had many patients who were out of range and weren't showing an improvement, potentially because of those drug gene considerations, we were concerned that we would lose sort of any buy-in that we had gained on the process. So we opted to exclude our populations initially that include drug-drug interactions, and our kidney transplant patients don't start those therapies at the time of their transplant. And so we thought this was a really clean population to really start to demonstrate value. And then liver transplant, we excluded because we didn't have a feasible workflow or support for testing the donor genotype in those patients that are transplanted, because we know that both the intestinal and the hepatic metabolism of tacrolimus matters. And without that additional genotype information, we really didn't feel comfortable making those dose predictions. So that's how we landed on only implementing in one of our transplant populations initially. Another really important consideration was we were incredibly lucky to have a very, very strong champion in our clinical pharmacist on the transplant team. But the other clinicians, when we started having these discussions, sort of although they were aware there were significant differences in metabolism of tacrolimus, the perception was that this really was rare. The genetics weren't common. They probably weren't having a large impact on our patients because our institution really does have a predominantly European Caucasian ethnicity. And so we wanted to show them this still does matter for our patient population. And we're very fortunate at the University of Michigan to have a very large biorepository of about 100,000 patients who have research genotypes that can be linked back to their medical record. And so we leveraged that resource to evaluate different clinical outcomes associated with therapeutic drug monitoring in our own cohort, what was happening to our patients retrospectively to try to show these differences. We intentionally did not look at rejection as a sort of way to leverage. If the randomized controlled trials that were much larger than our retrospective cohort were negative, we really didn't think that that was going to demonstrate the value. But because therapeutic drug monitoring can be so resource intensive for both our patients and providers, we really felt we could get buy-in if we were able to show differences between the genotype groups with these types of things. And so we looked at the initial tacrolimus trough concentration, the time that it took to achieve a first steady state therapeutic trough, as well as what the dose was for that patient at the time of their first therapeutic steady state trough. And we were able to bring this data back to our clinicians and really show, especially in the groups highlighted in red, none of our normal metabolizers were getting therapeutic initially, and it was taking over a month to get them into the therapeutic range. And even though there isn't strong ties to rejection, there's always that concern in that early transplant period that they're at a higher risk. So this data, in addition to the randomized controlled trials, the fact that there was a CPIC guideline, and we had a very, very strong clinical champion, was what allowed us to get buy-in from all of the groups that touched the kidney transplant patients to move forward with testing in all of our patients prior to their transplant. So after we sort of got stakeholder engagement, we then had to really demonstrate to them the feasibility of this. How were we going to do this? We do not have in-house pharmacogenetic testing, and so the way that our institution works is we actually have a laboratory formulary committee, and they make the decisions about what send out or external laboratories will be sent to. So we collaborated with them to make sure that we had a test that covered the appropriate variants, was relatively affordable in terms of cost, and could be integrated into our EHR to make sure that we were able to deploy clinical decision support. So I just want to highlight some of the considerations for when and how we're doing testing and how we're communicating that. Even though we were only implementing in one transplant population, when we thought about our processes for testing, we actually ended up identifying 3 different subpopulations who sort of required different workflows for obtaining that testing prior to transplant. If we don't have the test result in hand at the time of transplant, we aren't really showing the value of our testing process because we are only making that recommendation for the initial dose of the patient, and every dose after that is based on therapeutic drug monitoring. So it was really essential we find an existing time point in the patient workflow where testing could be performed. So for our living donor transplants, this was the most straightforward. All of those patients are evaluated within a week or 2 prior to their scheduled transplant surgery. And so at that visit, which is always on site, we were able to just add the pharmacogenetic test order to that visit summary, and it's always ordered prior to their transplant. But for our patients who don't have a living donor, when we can't predict when the transplant is going to occur, and we're really relying on a deceased donor, we had to come up with a different strategy. And so we took 2 approaches to this because we constantly have patients who are being newly listed to transplant, but we also have an active wait list of over 300 patients who are waiting for transplant and aren't necessarily coming to the healthcare system on a regular basis. And so for our new listings, again, we were able to find a time point where at their transplant listing visit, if there's a high indication that they are going to likely be listed for transplant, we go ahead and order it at that point in time. For our waitlist patients, we have 2 workflows because not all of those waitlist visits, which are conducted annually, are occurring on site. And we wanted to make sure that we were still able to get the transplant testing for the patients, even if they're not physically coming to our campus, and getting that integrated into our medical record. And so if they're coming on site, we get it, we perform the test at their annual visit. It's been added to their lab test orders. There's another panel of tests that they get at that same time, and we were able to easily add it to that. But for our patients who are doing virtual visits, we we're able to piggyback off of an existing workflow where they're actually mailing collection kits to patients' homes. That patient is able to take that kit either into their local laboratory or local dialysis center, depending on what's convenient for them, and get that sample drawn. We send a pre-packet or pre-addressed mailing envelope. It's sent back to our institution. So all of the testing is handled by us, and the test result comes back to us and is integrated into our medical record for results. And again, that was an existing workflow that was really feasible. And the fact that for our waitlist patients, we're only going to have to do this for a short period of time as we're catching up and we're going to capture every newly listed patient, we were able to get buy-in for that workflow. And it's worked pretty well so far. One of the other considerations for testing was the cost. We were able to justify the cost of the pharmacogenetic test by saying, if we're able to even prevent or reduce the number of tacrolimus troughs that have to be assessed by 2 or 3, that's cost negative. That's, neutral. We're not increasing cost for the patients. And if we can reduce it even further, then it's actually cost saving for the post-transplant management of that patient. We don't have that hard data, but our clinicians did buy into that idea. And so by saving those resources, both in effort as well as not having to deal with billing issues, we were able to get buy-in for the lab costs. And the decision was made that if the test was not covered by the patient's insurance, it would be absorbed by our pre-transplant cost report as opposed to being billed to the patient. So none of our patients receive a bill for this test. We also had to update our dosing protocol. Everything in this population is very, very protocolized. And so if the protocol is not updated, that's what our nurse practitioners, our physicians follow. All of that documentation had to be updated per the pharmacogenetics. And so we utilized both the CPIC guideline as well as our own internal data to come up with dosing recommendations. We do have a slightly different dose recommendation for our normal and intermediate metabolizers, still within the 1.5 to 2 times range recommended by CPIC, but we did separate those groups. And another really important consideration for our protocol and our education for our providers was which patients should not be receiving this. The vast majority are eligible for this program, but we do have patients who have had prior liver transplants, patients who are receiving multiple organs at the same time where they're receiving different protocolized treatment because it's not a single organ. Patients who are maybe getting a second kidney transplant, they're going to resume their prior tacrolimus dose because they'd already had therapeutic drug monitoring. And then right now we're excluding patients who are on CYP3A inhibitors or inducers. But once the dosing was established, we really didn't want to make the providers have to go back to the paperwork and documentation in the protocol every time they were prescribing this drug. And so we tried to leverage the existing ordering workflows within this population. So our adult kidney transplant patients, every single order they have after surgery is completed within an order set. So the initial dose of tacrolimus was never going to be a single order in our medical record. It was always going to be within this system. And there was concern that pop-up alerts in that process would be really disruptive to their workflow. And so rather than develop a pop-up alert or a more traditional alert, what we worked with our IT team to do was we actually are automatically adjusting the dose of tacrolimus based on the patient's available genotype information. So if the patient has a CYP3A5 normal metabolizer phenotype documented in our medical record, when the ordering provider, which is normally an advanced practice provider, opens and clicks on tacrolimus, it is automatically adjusting to that 0.15 milligram per kilogram dose for that patient and notifying the provider that that dose adjustment has already been applied. And so this was really positively evaluated by our clinical team. They liked the fact that they could reduce their alert fatigue. They didn't have to, they only had to remember reasons not to do it, as opposed, which is much less common than reasons to adjust. And then our other concern when we were implementing this was we didn't want these dose recommendations to get applied to other populations. We hadn't validated that it was appropriate in those groups. They had different protocols. And by targeting only this order set and not applying it to other medication orders, we were able to ensure that there wouldn't be other sorts of medication errors occurring in our population. So once we worked through that and launched that process, we really moved on to our implementation stage, which was this past fall. I just wanted to quickly highlight education and then some outcomes. So the other part of buy-in with some of our prior implementations, we try to do more general pharmacogenetics education. What was pharmacogenetics? Why is it important? How is it valued? And the perception we got from these clinical teams, especially with all of the other things they're managing post-COVID, was we just want to know what we need to know. And so we really tailored this education specific to the point of the implementation process that was important to their team. So because we have different providers caring for the patients prior to their transplant at the time of their transplant and after their discharge from transplant, we really only highlighted the components that were important to them. So our pre-transplant nurses are the ones who manage all of the pre-transplant visits, all of the test ordering, the mailing of the kits. So we developed a lot of education, a lot of resources for them so that they don't have to, think they can really be on autopilot for doing that. One of the other things we did with this group was develop one additional piece of clinical decision support, which was an alert to notify them if a test result was already available. Because we added this to an annual visit, and it's possible a patient may have multiple annual visits before they actually are undergoing transplant, we didn't want to have increased costs because we were ordering unnecessary duplicate testing. And so we do have an additional pop-up alert that essentially says, this patient already has a CYP3A5 genotype available. Please don't order this test again unless there's some clinical reason to do so. And that's been very well received because they don't have to hunt the chart and try to find that piece of information. And then we also did brief education with the surgical team in nephrology about our protocol updates. And then one of the other pieces that was much more informal was we targeted education to our hospital pharmacists. Only one location in our hospital receives the transplant orders for verification. And so we just educated those pharmacists, hey, you're going to see higher doses of tacrolimus. You don't need to page the clinical team. This is the protocol that's being put in place to try to reduce any confusion for them as well. So I just wanted to quickly share some of our preliminary program outcomes. So we launched the program in October of 2023. When we launched, because of some staffing shortage issues, we were only doing the on-site collection of samples for our living donor and newly listed patients. And over time, we were able to then actually implement the mailing kits in February of this past year. And as you can see, we've been tracking the proportion of our patients who have had the genotype available at the time of their transplant. Started off very low, as expected, but we're now reaching the majority of our patients who are being transplanted do have that genetic information available. Since launch, we've had 154 kidney transplants occur at our institution, and I'm very pleased that we're approaching, at around 40% of those did have genotype information available, and as that proportion increases, we are planning on taking sort of next steps of looking at pharmacokinetic, economic, clinical outcomes in these patients, making adjustments to our dosing protocol if needed. And having even this just preliminary data showing feasibility has really increased the interest of having this type of program with our other transplant groups. And so we're in active conversations with some of our other transplant teams about how can we take or modify this model to apply it to their patient population as well. So as many as have mentioned, this is very much a team effort, not on our own. I just want to in particular highlight Jamie Park, who is our transplant specialist that was really our clinical champion in the kidney transplant space, our Precision Health initiative that has supported documentation in our medical record, which makes a lot of this feasible, and then all of the clinical teams that help care for our transplant patients. So thank you. I'm happy to take any questions.
Well, how about we take one question from one person, because we're behind.
Oh, thank you.
All right, up here, April. Oh, sorry. Back there.
Which one?
Save it for the panel. Go ahead.
Okay. Thank you. Nice talk. Are you planning to expand testing to other genes, or are you already doing a panel testing, given that this population is most likely to be receiving other PGX medications?
Yeah, it's a great question. I would love to be doing panel testing. Right now, it's a single gene test. Buy-in was the biggest barrier to that. Our clinicians were, they were learning about CYP3A5 and tacrolimus, and to ask them to think about other drug gene pairs at the same time, we would have lost a lot of buy-in in terms of doing that. And so we really took the approach of demonstrating the feasibility with the established drug gene pair they were comfortable with, and we're hoping that as they see that this is possible, we'll be able to convince them, okay, we can make this on other medications, we can improve these workflows in other areas as well.